Herpes zoster, commonly known as shingles, is caused by the reactivation of the latent varicella zoster virus and presents as a painful dermatomal rash. It has recently been suggested that the lipid-lowering drugs, statins, may cause a small but significant increased risk of zoster. As statins are widely recommended worldwide for the prevention of cardiovascular disease, any adverse effects have potentially substantial public health implications. In this paper, we aim to quantify the effect of exposure to statins on a patient's risk of zoster in the general population of the UK.
Using prospectively collected electronic data from UK primary care and linked hospital records, we carried out a matched case control study. Patients over the age of 18 with a new diagnosis of zoster were matched to up to 4 zoster-free patients who were of a similar age, the same gender, and registered at the same GP practice. We then looked back to determine if they had ever been prescribed a statin, the dosage of their most recent statin prescription, and the time since their last statin prescription. We used conditional logistic regression to estimate the odds ratios and 95% confidence intervals for statin use in relation to the outcome of an incident zoster diagnosis, accounting for a range of possible confounding variables. We also explored a potentially effect-modifying role of age at diagnosis of zoster on the relationship between statins and zoster.
(144,959) patients with zoster diagnosis were matched to 549,336 zoster-free patients. Our main analyses found a strong evidence for a 13% increase in the risk of zoster in patients that had ever been prescribed statins in comparison to those with no history of statin use. We also reported an increase in risk of zoster as a patient's statin dose increased in those who were currently or recently prescribed statins. As shown in the top part of the table, the odds ratio for lower dose statin use in current statin users was 1.14, rising to 1.27 for high dose statin use at the time of their zoster diagnosis. A similar trend was seen in those patients who had recently stopped statins. The figure shows that we also observed an attenuation of excess risk as a patient's time since their last prescription increased. Current users were 14% higher risk of zoster, whereas those that stopped more than 36 months ago had little evidence of an increased risk. However, there was no evidence to suggest that age modified the effect of statins on the risk of zoster.
We have shown that exposure to a statin prescription is associated with a modest increase in the risk of herpes zoster. These results are similar to those reported in Canada and Taiwan. However, our study additionally showed that the increased risk of zoster disappeared amongst people who had stopped taking statins some time ago. This is consistent with a real causal effect. It is clear that the preventative benefits of statins are likely to outweigh any modest increase in zoster risk in many cases, but this evidence should be taken into account when prescribing statins to those at high risk of zoster. We would also suggest that these findings may provide an extra motivation to maximise zoster vaccine uptake among eligible patients who are also receiving a statin.